Hello to all of our quality-minded listeners. A special shout out to our Mayo Clinic Care Network members. Welcome to Key Into Quality, a Mayo Clinic podcast focusing on healthcare quality, trends, and solutions. Today, we're diving into human-centered design, a powerful approach to improving both patient care and staff experiences in our hospitals. Thank you for joining us. I'm Dr. Tim Morgenthaler, a professor of medicine here at Mayo Clinic and a vice chair for Mayo Clinic Quality. Co-hosting with me today is Sherry Nemec. Sherry?
Welcome, everyone. I'm Sherry Nemec, Consultation and Relationship Manager for Quality at Mayo Clinic. You know, Dr. Morgenthaler, I know I've mentioned this many times already, but I have a special interest, it's close to my heart, around patient experience. And, you know, Mayo Clinic's primary value, the needs of the patient come first, has greatly influenced about how we think about and approach concepts of human connection and patient experience. So today's topic fits right into that.
Sherry, before we dive into it, I've always wondered, you have had a passion for patient experience since the day I met you. And I'm just kind of curious, does that come out of your experience as a patient or out of your joy in helping improve patient experience, or both? Where did that come from?
Yeah, so not so much the patient part, but just a passion for people. So master's work in counseling, but I never really kind of went into that path and came to Mayo Clinic and started in education, leadership kinds of things. But then quickly in 2006, I got started with learning more about patient experiences and getting feedback and all those things. And so, yeah, I've been around a while in this space.
It just occurred to me, we've worked together for so long and I've never really asked you that. So thanks for sharing that with me after all this time.
Thanks for asking.
So joining us today is Allison Matthews, who is the lead of experience design in hospital operations, and she specializes in creating spaces and workflows that truly meet the needs of those who are going to use them every day. And I can't really wait to learn more about design thinking and how using those tools might help us to better our environments, enhance our efficiency, support well-being for both patients and the caregivers that are working in those spaces. Now, I don't know a lot about design thinking, but as I understand it, it is a problem-solving approach that really strives to put people at the center. So we're going to hear a lot more about that. It focuses on understanding the needs and brainstorming creative solutions. And every time I hear one of these talks from people who work in this space, it's very exciting. So I'm looking forward to hearing about real-world applications and strategies that can help make differences that we can feel and see and smell maybe even in our hospitals. So Allison, welcome to our podcast. Maybe you could just start by telling us a little bit about yourself.
Great. Thanks for having me. I'm excited to be here. I'm Allison Matthews. I am a service designer by trade. I was trained as an architect prior to coming to Mayo Clinic, and I've worked at Mayo Clinic for about 15 years. I originally started at the Center for Innovation, where I served as a service designer there, and I now work on the Bold Forward Unbound in Rochester project, where I serve as the design lead. And I've worked on a wide range of projects. I've worked on everything from a care team redesign in primary care. I've worked on CAR T cell therapy. I've worked on spaces. I've worked on apps. So it's been a wonderful way to infuse design into how healthcare is delivered.
Allison, when you got your training in design, were you already thinking about healthcare, or did you just land there the way a lot of us land in our jobs through, who we met or whatever?
It's a great question. I actually went to medical school before I got my master's degree in architecture. I was a Mayo medical student, and I got about halfway through medical school, and I realized that I was interested more in kind of the systemic issues in healthcare than I was in individual patient care, and decided to tackle that through architecture. And then graduated in the recession when no one was building anything, and was able to work at the Center for Innovation, where I can combine healthcare and design that way.
Wow. You're like a polymath of design. So healthcare, as you know, is just so complex and there's so many moving parts. Can you maybe help our listeners and me start by explaining what human-centered design and service design mean in this context, and how do they help improve patient and staff experiences?
Yeah, absolutely. Human-centered design in healthcare is something that is part of a larger system always. So it's never really something that you do exclusively when you're designing a care methodology or a space or a technology. So we work together, but our approach is different than a lot of others in that we focus really on the experiences that people are having and trying to understand how to make those better. Other methodologies often focus on things like efficiency or waste, and we are really looking at what people are experiencing, how we can improve that, and if we can look at some of the root cause issues. I think one of the things that's most exciting about a lot of the projects, especially that I did at the Center for Innovation, is that we would ask them to come with a problem, not a solution, and that we would look at it very holistically. And so when I went into a project, I didn't know if I'd be designing a space or a role or a technology. It could be any of those things. And we were given the freedom to really look at it that way and say, what does this system need and how can we improve it that way?
Many other people who work in quality improvement, and a lot of our listeners are interested in quality improvement, they do think about concepts like waste or efficiency. And so their units of measure are often things like defects or defects per unit production or costs or things like that. What are the units that you use for human experience?
Great question. It's highly variable and it's really dependent on the situation. But I will say first though, we also do look at waste and things like that, and that tends to come out as part of the larger story, as one of the root cause issues that we're working against. So it depends on what the project is. So if it's something where we've been brought in and they say, like we really aren't able to get all the patients who want to be seen into this clinic, then we will build our metrics around that. Can we get more patients in? Can we serve more people? But it wouldn't be about just improving the patient numbers. It would be saying, how can we provide guidance and support to as many patients as possible? So it may become something like patients reached, and that could be through both appointments, or it could be through virtual care, or it could be through knowledge. And so it takes a broader approach at it. And so often in the beginning, the metrics can be somewhat ambiguous with a goal statement, and they become more clear as you get into the project.
So Allison, at the beginning, you were telling us the wide range of things that you have been involved in. So do you have a story or an example you can share with us on how human-centered design has made a real change in how care is delivered?
Sure. One of my most favorite ones to talk about is the CAR T cell therapy service line that we worked on. And when we were brought in by Dr. Elin, and she was fantastic in that she really wanted us to look without any barriers at the whole system and to take a very design centered approach to how we designed the CAR T cell therapy service line at Mayo Clinic. When we first came in, there's a bit of an assumption that we would be building a patient app that would help patients along the way. And what we did throughout the process is we first shadowed patients from end to end. We went to their homes, we spent time with them in all of their different appointment types, we were with their caregivers, we were with them through the entire experience. We also shadowed the care team, and then we also shadowed the operational staff who was supporting it. So groups who were helping with the cell therapy aspects, and we talked to the different manufacturers that we were working with. The next step that we took is we brought everyone together for like an entire day summit to talk through from end to end what the process was. And this was really fascinating because everyone had very clearly articulated their small portion of the experience, but they didn't know what was happening in the others. They realized through that there was some redundancy. So there's your waste, it comes out naturally. They also realized that there were at times telling people things that weren't necessarily true about what would happen in the next step, or they might be doing something that's conflicting with what they might hear later on. And so as we began to do this, one of the things that we realized, and that's one of the nice things about design, is we have this thing called insights where you kind of are able to see these big moments that can shift how you're thinking about things. And we realized one of the big things that was happening in CAR T cell therapy is that these patients had already been through several modes of therapy already. So they'd kind of exhausted their caregiver network. And so the people who were coming with them serially. So I can come on Tuesday, but then Sherry can come on Wednesday, and then Dr. Morgenthaler can come on the next day. And so they were sharing information with various people. The intervention that we developed. So, first, one of the interesting things about design is that you don't necessarily try to solve the problem first. You create different things to kind of poke at the problem to figure out if your assumptions are correct. So we said, okay, well, they're hearing a lot of different things. The people in the system need to have some continuity, and people are thinking about an app. So why don't we make a paper version of this app? And we built a thing that had every single interaction that the patient would have. It would have suggested questions that they could ask. And we made it into like a little booklet. And we called it a workbook. And that workbook would go from caregiver to caregiver, and the patient would fill it out. And the things that we learned were really fascinating. One, we learned that the caregivers loved passing this back and forth between each other. It really gave them a sense of like, oh, I have the responsibility. I will write things down. And it was interesting that way. It was even interesting though in terms of the care team, because when the pharmacist was talking to someone and they would ask a question that maybe was better answered by social work, they'd say, let's flip to your social work page and I'll write down the question there, and that you'll get that answered when you meet with that person. And so as we kept going on with this, people kept saying like, where's their workbook? We need to give them a workbook before we can have my appointment. So we were seeing this innate value. We then said, what else can we add to this to make it better? One of the things that we learned is that patients with CAR T cell therapy often have neurotoxicity. And we would go to all of these appointments with the patients, and the providers would talk about this neurotoxicity. But when the patients experienced it, they'd say, no one talked to me about this. I'm shocked that this is happening. This is something that I'm really surprised by. And the caregivers would also say it. And we realized that we were talking to them in medical language and they needed this in experiential language. So, what we added to the workbook was pages where different patients would talk about the experience that they had. And all of a sudden, the next patients who got that said, oh, this is what I should expect. So it became this like really interesting kind of palimpsest, really fun, tangible thing that we were experimenting with. Then we began to say, what if this goes on an iPad? Like, what if we turn this into an app? And it lost its efficacy. It was no longer something that people were passing back and forth. No provider's ever going to take your iPad and write a question in it for you. The tangibleness of this workbook became this really interesting connection between the patients and the caregivers and the care team that was holding this all together. And so in the end, what we made, it sounds kind of like a downer, like we made a workbook. We made a series of these really nice workbooks that they review periodically, and every person on the care team has a few pages that they go into, and it connects the patients to the care team. It connects them to patients who have already gone through this and they know that they're not alone. And we find these workbooks that are like dog-eared and covered in coffee stains and have all of these notes back and forth with each other. And the other thing that we did is we made it so that we broke it up into 3 workbooks. So you feel as though you've graduated and you're making progress through this experience. It was just a really fun project.
Oh, wow.
And if you wouldn't have gone through all that, right? Like you said, they came with this idea that it needed to be an app. Well, let's spend all this time building an app and then it flops because that's what people wanted.
Right.
I think that is really such a prevalent thing in healthcare. It's probably not only in healthcare, but a lot of times people come with a solution without really understanding what the problem is. Or I just think that's so exciting that you kind of learned that it's that having that workbook. I love the way you describe it with the coffee stains and everything on it. I wonder if people hold on to these as sort of tangible memories, souvenirs of their journey. And, our listeners may not know this. We've been talking about CAR T therapy. That's an abbreviation, and it stands for chimeric antigen receptor T cell therapy. So it's not something that rolls off the tongue, but it's actually a form of immunotherapy that is used mostly for certain kinds of blood cancers like leukemias and lymphomas and multiple myeloma. And so, as you said, many of these patients will have been through already other therapies that were not easy either. And it is important. It's an important learning that probably has not been written about very much, that their care team, their family members, they've probably already exhausted all their time away from work. By the time they get here, they really do need that way of communicating one to another and feeling like they can still be part of the team.
Another really kind of interesting insight that came out of it, I think to your point, is do they save this over time? We learned 2 other things, kind of observing and experiencing things with them. One is that whenever they go home, they need to communicate with their community what's going on. So the neighbor says, what happened when you went there? And they can say, here, this is my workbook. Let me walk you through what it is. And the other really interesting thing was when they finished their therapy at Mayo, we do a wonderful job of sending a letter to their local provider. But what we learned is when they go to their local provider, the first question they say is, what happened at the Mayos? Like what happened with you? And the patient has a responsibility of sharing with them what their treatment was. And so we created in the workbook a worksheet, kind of a Mad Libs format for the provider to fill out and said, this was the date of my therapy. These are the things that I had done to me. These are the complications that I experienced. Here are the things you should call Mayo Clinic for, and here are the things that I can be treated locally for. That, of course, all went in a letter that officially went to their local provider. But the patient is expected to communicate this as well to their local provider. So we set it up so that they just really needed to read that to them
Sort of
and they were
unburden
ready to
them.
go. Yeah.
Yeah. Healthcare, as we started out talking, is very complex. I mean, there's a lot involved. There's the interpersonal transactions, there's the application of scientific knowledge, there are these huge teams. I mean, taking care of a person with leukemia or lymphoma involves, I don't know, hundreds, maybe thousands of individuals for that one person to take care of all the laboratory and so forth and so on. So it really involves clinical needs, it involves operations, there's regulatory oversight over all these things, there's technological development. When you work with your design process, how do you make sure that the design isn't just about a good idea, but that it actually leads to real change? And how durable is that change?
There's an interesting point in every human-centered design process where you have a very agreeable idea. Patients should have a louder voice in appointments. Doctors should have more time without having to do as much documentation. There's these very kind of big ideas. And one of the most interesting things about my job is that I need to dig in and understand what are the things that are preventing us from doing this very obvious idea. There are a lot of things. There are regulations, there are different kind of competing needs that are happening, and so we really have to dig in very carefully to understand what those different aspects are. And one of the things that people say in design a lot is that very good design comes from having constraints and comes from having just like really different ways that are kind of keeping you on a particular road and developing a very specific solution. So early on in our process, we're often looking for what are the constraints? What are the things that are keeping us on the road that we need to be on? What are the rules that we have to play with? But the other interesting thing about design is that we're allowed to push on some of the rules too. So could we find a way to move the regulations? Can we find other ways to interact with the patient? Are there different ways to be reimbursed for this service? So we ask a lot of questions that I think if you come into a project and are just kind of going towards a particular target, you don't often ask. Sometimes it's a great idea and it helps you move towards something that you hadn't expected. Sometimes no, it really is a hard no and you have to maintain that constraint. But one of the things about design is that we're always really curious. We test these things not just through thought exercises, but we also try them out. And so we do a lot of prototyping, we do a lot of iterative design and try to deeply understand the system that we're working in and design for that rather than designing some kind of product that then kind of gloms onto a complex system and doesn't do anything to make the system itself any better.
So in your experience, Allison, what are some of the biggest barriers of bringing design into healthcare, and how have you found ways to work around them?
So I think there are several barriers. One is design just isn't known terribly well within healthcare. It's seen as maybe something fluffy and extra. So that's one challenge.
Nice to have, not necessarily need to have. Yeah.
Exactly. We also tend to slow things down a little bit because we ask big questions and we can at times blow up a problem that felt like you're going towards a very simple solution and now we're questioning the whole thing. So that's also a challenge. I think there's also just challenges with understanding how design fits within a broader spectrum of ways to approach a problem. And then I think just resources. There aren't a lot of designers in healthcare. And so, like, especially smaller healthcare systems often say, how can I do this? But healthcare design is really a way of thinking about things and allowing yourself to be a bit unconstrained. Admittedly, after like taking some time in medical school, it's kind of the opposite of how doctors think. So a doctor is trained to walk into a room, assess a situation, come up with a set of ways that we can approach it, and then advocate for those. My role is to walk into a room and just sit in the ambiguity and allow it to kind of be ambiguous and just really try to allow the complexity to be what we're looking at. And so a challenge sometimes is that it's just a very different way of thinking about things.
As you're describing these challenges, I'm kind of sitting here thinking, okay, so you've been at this a while. Some of what you're talking about is difficulty in getting people to take a moment and think about things differently. They're maybe feeling very pressured to get me the solution right now. What are some of the things that you've learned about how to help people become collaborators, contributors, co-conspirators, if you will, versus adversarial type of relationship? What are some of your tricks?
Yeah. One of the good things about design is that we tend to be pretty good storytellers. And so while we can be in a room with an entire care team who is very clearly articulating what it is that they would like to do, no one's ever kind of consolidated into a slide deck or a diagram or just, like a write-up of like, this is what the problem is, this is what we like to solve, this is what we aspire to do. So first, that is always the beginning, is I try to help them make sense of something that's a bit of a hairball. The next thing is I really encourage everyone to look at what we're approaching from a different perspective. And I think everyone always intends to do this, but they don't always kind of sit in it and allow it to happen. So if I'm working with a care team, sometimes I'll say, could you shadow each other? Can you ask questions that you wouldn't have asked normally? Can you write down your approach and compare it to someone else's? There are a lot of assumptions, and a thing in design is that we really try to get past those. And so how can I help reveal those organically so that the team feels that they're doing it? Another thing is designers, if we are forgotten at the end of the project because people say we had this great project and we had this great idea, that's the best thing. If no one remembers that I was involved, that's just great with me. And so it's really allowing people to take ownership over these kind of new ideas. And so it's really that you're just along the way the whole time, storytelling and helping them articulate what it is that they're aspiring to do and giving them ways to approach it. So it's a very collaborative process.
We usually ask our guests at the end to say, if I'm a leader listening today, and like you said, maybe I'm a small organization, I don't have these kind of resources. What's one small step that I could do to move towards this kind of thinking?
Yeah, I think one way to do it is to, as you're doing other maps that naturally happen with quality improvement projects and kind of, waste walks and things like that, add in the experience, add in what people are thinking and they're feeling and what they're doing. And think about, is this an opportunity space for us to lean in? And the second thing I would say is, as you're doing that, allowing yourself to have a question of, is this the right process at all? Are we improving a process that should be improved, or should we look at this more holistically and take an approach that maybe says, let's think of something else and a different way to do it?
I know that our listeners are thinking we don't all have access to a medical student, architect, designer person. And this has just been a wonderful opportunity to hear how you think about these things and learn some of these processes. But we do have to come to the close of our podcast. Is there anything else that you would like to share with our listeners before we close?
I would just say that anytime you have the opportunity to engage with design or to think about things differently, to run in head first and just enjoy the process.
We don't have a visual on this podcast, but I wish that we did, because our viewers would see that the whole time you've been talking, you've been smiling. And I'm sure that that is because it's a lot of fun what you do, and you have been able to kind of do something that you're passionate about and use it to help other people. So thank you so much, Allison, for sharing your time with us, Sherry and I, and with our listeners. We're really grateful for the things that you do and for what you've shared. So thank you.
Thank you. It's been absolutely my pleasure.
For our listeners, again, this is Mayo Clinic's Key End of Quality podcast, which aims to highlight some first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and the populations that we all serve. If you enjoyed this podcast, we'd be grateful if you left us a review on Apple Podcasts, a rating on Spotify, or feedback wherever it is that you listen. You can also follow us on your favorite podcast platform. Let others in your organization know about the podcast so that the information can be shared. Until next time, goodbye.